This is really an indications talk, and you're going to hear the good surgical stuff to follow this. So I have no disclosures. So why do we do total ankles? Well, we think they have better function. I think there's more and more studies showing that they have somewhat better function. And then we also think they preserve the surrounding joints. But the problem is with all total ankles, they're going to eventually fail. And when they fail, we have to do something. And that something may be a revision. I think we have better revision opportunities now, but there may be a fusion. And if you have to do a fusion after a total ankle, it's a difficult problem. It's risk for patients, and they're less satisfied. So we need to really have good indications. So we're going to look at how these factors play a role in total ankle arthroplasty. And to do that, we first need to look at what are the general outcomes. What do we know about total ankles to date? And I think we have fairly good information on three of the earlier prosthetics. And so the STAR probably has the longest term follow-up. This is a study that came out in JBJS in 2013. It looked at 77 ankles with over 12-year follow-up. And they had about a 38% revision of the metal with an implant survival of 70% at 10 years and then 45% at 14 years. And this particular implant had some poly problems, and they changed the poly, which I think helped significantly. Tim Daniels did another study, came out in 2015, looked at 111 ankles at 9 years, 12% revision rate at 4.3 years. But again, this was early with the bad polyethylene. Another study in FAI, 134, 7.5 years, 78% survival. Salto also has some reasonable studies up to almost 9 years, 89 ankles, 35% reoperation, 85% overall survival. I would tell you, I think the reoperation rates and the number of surgeries that we're doing after total ankles is markedly declining. People are being better trained in them as fellows, and so they're not kind of learning on the fly now. And I think these are really, reoperations are decreasing. And here's another study, 2014, 98% survival, but only 43 months. Another study, 97.5% survival, only 5.2 years. So the shorter the follow-up, the better they do, right? So this is another one, 96% survival rate of the Salto at 5 years. What about the in-bone? And the in-bone's changed a little bit too. It's gone from the in-bone 1 to the in-bone 2 to a better prosthetic, 194, less than 4-year follow-up, 89% survival. My dad had 59 at 35 months, 97%, 96, 97% survival. So how does age impact this? Well, again, we're going to see a bunch of studies here. This is a study out of Duke. They looked at those that were less than 55, 55 to 70, and greater than 70. Only 3.5-year survival, and no difference in outcomes based on age, whether wound problems, reoperation, revisions. Another study, 103 patients, again, only 41-month follow-up, 2 groups, less than 50, greater than 50, no difference in complications or survivorship. Same thing here, looking at STAR, 54, average mean age was 54 years, 87 stars at 15.8 years, survival 76%, age was not associated with early failure. The problem is that, these things are not lasting forever. And if you do something, do one of these on somebody who's 50, what are we going to do with them at 70? I don't think we know yet. This is another part of the Daniels study. The mean age was only 61 years, 12% revision rate at 4.3 years, 18% poly. Age was not associated with failure. Another less than 55, greater than 55, no different in clinical or radiographic outcomes or survival rates. Now, what about obesity? So this is just how you can look at obesity. For a 5'9" male or a 5'5" female, it seems like every 35 pounds you go up 5 in your BMI. So this just gives you an indication. BMI is a little bit criticized now, but I guarantee if you have a BMI of 40, you're significantly overweight, and that's all there is to it. this guy, I used to like him, and then he went to the Eagles, so I don't care about him anymore. But his BMI is 32, and you'd ask, so is he too big? Is he obese? No. So when you look at these studies that look at obesity, Daniels again study 39 patients BMI greater than 30, and 10 of them had great BMIs greater than 40. But again, only 4-year follow-up, 48 patients, less than BMI of 30, less than 4-year follow-up, no difference. Barg, another study, no difference in pain and function significantly improved. Study by Gross, this is a really big study. But again, if you look at the BMIs, the follow-up is, again, less than 4 years on all of them. They noted the obese patients had lower function, not surprisingly, but they overall had better functional improvement, better pain. Revisions were all the same. Haddad's the only study here that showed that obese patients with primary osteoarthritis had increased risk of failure by 5 years. And this is my favorite study by Penner. This came out in 2012, 145 overweight and obese follow-up at 6 months, 2 years, and 5 years, successful total ankle or fusion, but there was no change in their BMI. And I think you see this in the hip and knee literature as well. People say, I need, you got to fix my ankle so I can start working out and lose weight. Doesn't happen, right? So, and it doesn't happen in foot and ankle either. Rheumatoid arthritis, these people have bad skin, they have bad bone, they have bad immune systems. So there's always a concern. Drugs certainly help these days, and these patients do better. So this is a study out of 2014 JBJS, 50 patients with RA, 50 patients without. They were followed, again, reasonable follow-up, 64 months, 66 months, no difference in revisions in rheumatoid. There was one deep infection, none in the other group. Study out of Japan, 57-year follow-up, 48 of 50 had no revisions, talar subsidence in 8 ankles. So not terrible results in the rheumatoid group. What about diabetes? There's a couple of studies out there. These studies don't really say that the patients had or did not have neuropathy. The assumption is they really did not have neuropathy. They had 50 patients with diabetes, 50 patients without. Follow-up was really short in this, 2.3 years versus 3.1 years. But they're looking at early complications in this group. There's no difference in failure rates. I don't know what you can make of that with only short follow-up. This Shipper study, again, complication rate in diabetics 7.8%, non-diabetics 4.7%, higher rates of transfusion, non-home discharge, overall complications. Smoking, I'm just going to say absolutely not. They do have a higher rate of wound complications, and if they don't stop smoking, I'm not doing a total ankle. I'm happy to do a fusion on them, and I explain the risks of that, but I won't do a total ankle on smokers. So all total ankles will eventually fail. So if the earlier you get one in life, the more likely you are to have a failure. And then what do we do about it? However, people do well with total ankles, and it might help their lifestyle early. So that you have to consider that. Salvage is not always successful, often complicated. I don't think we can get anything out of the studies just yet. They're all too short a follow-up. I think you need to use common sense. So I try to get patients to be at least over 55 and have subtalar arthritis. I try to get them closer to 60. I try to keep their BMI, under 35 if I can. If I do rheumatoids, it's really all about meticulous soft tissue handling. You want to make sure your diabetics have good control, no neuropathy, and you need to have a detailed discussion with them about the risk factors. So just a couple of cases that are a little bit against what I just said. So this is an older patient. She's 88 years old. She's really active. She's independent. She's also a big donor to the hospital. So I was getting a lot of pressure because she wanted a total ankle. And here she is. So now she's 91, 3 years later. She's very happy. She's very independent, and she's doing well. And actually, she came and saw Dr. Claire. She had some kind of issue while she was down here in her Sarasota, and he said she's all fine. This is 72-year-old. Now her BMI is 40. She's got pantalar arthritis. She's got a cavus foot. If you do a pantalar fusion on a big, overweight 72-year-old, this has the potential to have a lot of complications with a really long recovery and a not great satisfactory outcome. So I did do a total ankle on her and at 1 year, and I think I just recently saw her again. She's doing pretty well at about 2 years. And now this is the youngest patient I've done one on. It's 49-year-old, relatively well-aligned foot. Here's 2-year follow-up on her Infinity, and she's happy as could be. The reason she got an ankle replacement is because she absolutely refused a fusion, and I couldn't just say no completely. So, indications about everything.